Okay. So good evening, everybody. My name is Oreste Gentilini from Milano, Italy. I have the pleasure to start and to moderate this first webinar about the Cinderella project. Cinderella is an ongoing prospective randomized trial evaluating the use of artificial intelligence to hopefully improve the matching of expectations concerning cosmetic results for patients undergoing breast cancer surgery. Today, we are very lucky because we have an outstanding faculty indeed, so I encourage all the attendees not to lose this opportunity and to ask questions to our faculty. Yeah, and therefore, I think that without any further delay, well, obviously, you can use the question and answer tool in order to ask questions. So it will be my duty to deliver and to forward your questions to our panel at the moment of discussion. So without further delay, I would start with the first speaker, who is Isabel Rubio. Isabel is head of breast cancer surgery at the Clinical Universidad de Navarra in Madrid, Spain. She's also the president of the European Society of Surgical Oncology. And Isabel is going to give us a talk titled Different Surgeries in the Curative Setting for Same Stage of Disease Surgical Consideration. So Isabel, please.
Thank you, Oreste, and thank you for inviting me to this webinar that I think it's really interesting and can give us a little bit of what is going on with artificial intelligence in the breast cancer surgery field. So let me move my slides. If I have the control, okay, well, it seems that. Okay, these are my disclosure, non-related to this lecture. And of course, we already know that breast cancer represents a global health challenge. And this is data from Europe that we can see that almost 400,000 patients were diagnosed with breast cancer 2 years ago, and numbers are increasing. So it's the most commonly diagnosed cancer and one of the most commonly causes of death for the woman. So I think we are really looking into an important problem in the woman population. I don't think okay, now. So we've seen massive improvements in along the years in breast cancer. And I think that breast cancer is probably one of the cancers that has most evidence base in the practice and progress in improvement treatments, in survival, in cosmetic quality improvements, in reduced surgical morbidity, and in the multidisciplinarity. So the patient experience, in the 17th century was terrible because they didn't have any information. They couldn't choose anything. And at that time, I think that nowadays things has changed so much. And nowadays with the shared decision making with the patient, we have get to a point that patient's preferences and patient options are really an important issue here. Of course, we need to remember the change in the paradigm of treatment of breast cancer from the more radical procedures to the conservative surgery. And this is something that has shifted from the radical surgeries, maintaining the oncological outcome, but also improving patients' quality of life. And from breast conservative surgery and mastectomy, just two more options in the field of cancers in breast cancer surgery. And we have seen the oncoplastic breast conservative surgery nowadays as a standard breast cancer procedure in the daily practice. And why this happened? This happened because in many cases in the breast conservative surgery, there was an optimal oncologic outcome, but there was a suboptimal functional outcomes, meaning impacting the quality of life of patients because the results of the surgery, the bad cosmetic outcomes, the suboptimal cosmetic outcomes were impacting in the patients. So we realized that there were some limitations and challenges to the breast conservative surgery, and this was the tumor size, the location, the volume that we excise in multicentric tumors. So we need to make a change in the way we were doing surgery to try to get better cosmetic outcomes. Of course, you know, there has been hundreds of thousands of reports looking into the oncoplastic procedures, but I think that what is important is that where the tumor is located and how much breast tissue we need to excise, it will drive to a better or a worse cosmetic outcome. And as you can see here, when we have breast cancer in the areas in the internal quadrant, so in the lower outer quadrant, if we excise a lot of tissue there, we will have very bad cosmetic outcomes. So nowadays, we can see that, for example, in this picture, when we have a tumor in the lower outer quadrant, if we excise not a lot of breast tissue, but we can have these results that, you know, are suboptimal cosmetic outcome. And maybe the patient is cured and maybe she will live many years, but she will have a decrease in the quality of life and the satisfaction. When we have tumors in other quadrants of the breast, you know, this can be done with better cosmetic outcomes. So we have different, and I'm not going to go into this because I think it's away from what we are talking, but just to realize how many different techniques we can offer the patient now and how many techniques we need to make a decision with the patient, which one is the best that fits not only for oncologic outcomes, for cosmetic outcomes, but also for patients' preferences. And this is really, you know, a very ongoing thing that we need to do and getting more and more complicated. So, you know, now we can have reduction mammoplasties, we can have grisotis taking out the nipple area complex, and we can have, you know, simple breast conservative surgery depending on what I mentioned, the tumor, and depending on the preferences of the patient where it's located, and so much more. There are many different ways of looking into which is the best technique for what type of breast and what type of tumor and where is the location of the tumor. And as you can see here, if you explain this to a patient, this will be like kind of a nightmare. Of course, you know, the oncoplastic techniques has shown that there is no difference in locoregional recurrences compared to the breast conservative surgery, and this is already seen in meta-analysis, also retrospective, prospective studies. So we know that these techniques are oncological safe, and also, you know, you can get better cosmetic outcomes for the patients. But just because we can do a complex and interesting operation, it doesn't mean we should do one. And I think this is important. We always need to make sure that simple is often the best. So the vast majority of women, mainly in those countries that there is a screening population programs, we see patients with a stage 1 disease. Many patients can just have a breast conservative surgery, but also they need to understand what will be the effect on their breast after the surgery. Also, you know, when we not only about talking about breast conservative surgery, talking about mastectomies, we have come up to the same situation as with the breast conservative surgery. It's not just a simple mastectomy as we had many years ago. Now we can have skin sparing mastectomies, nipple skin sparing mastectomies, different places to put the scars, to put the incisions, different way of doing it, whether it's open surgery or starting with some also endoscopic surgeries. And this is something that also the patient needs to know and need to understand which one is the best that fit her. Of course, we have many other imaging that can help us to decide what type of reconstruction, how can we preserve the nipple area complex, and so on. So I believe that from the standpoint of the imaging before the surgery, we can understand what options has the patient, but now the patient needs to decide what is the best option for her. And also, you know, when we decide about breast reconstruction, you can see how many different type of implant-based reconstruction that we can have. We can do different type of incision. We can do it subpectoral, prepectoral, and there are studies ongoing about this. We can use different materials, different shape of implant. So as you can see, you know, we are keep going with so many different options. We can have autologous breast reconstruction in another time. And, you know, and you can see that above the already used DIEP reconstruction, there are other type of autologous breast reconstruction that can also be used when we don't have the usual ones that are the DIEP or the latissimus dorsi. But then radiation therapy came into place. And then, you know, if we have radiation therapy, we know that radiation therapy will decrease the cosmetic outcome of the surgery. And in some cases, also we increase a little bit the complications, even though I have to say that those complications, as the more experience, the less complications, but still the cosmetic outcome will not be as good. And, you know, depending on whether you know that the patient is having radiation therapy after mastectomy, you know, you can have different type of techniques, whether you don't know or whether you think it's improbable. So if you can imagine how much things you have to discuss with the patient when the patient is sitting in your consultation room after being diagnosed with a breast cancer. And there are complications that we already know, and from the nipple skin sparing mastectomies, we have here already more than 1,000 of patients looking into complications, not only the hematoma and infection that are complications from any surgery, but also flap necrosis, nipple necrosis, or implant loss. And I think this is something that you also need to share with the patient when they are deciding what type of mastectomy they are having and reconstruction. Well, you know, the breast surgery comes along with the axillary surgery, and sometimes the cosmetic outcomes of the breast are related to what we do in the axilla. And as you can see here, when we talk about what type of axillary surgery, it all comes to a whole different options, depending on the patient is going under neoadjuvant or upfront surgery, and depending on whether they have a positive or a negative axilla, you know, we have different options. So you can see how much time consuming is deciding what type of surgery is the best one that fit the patient with their tumor. But I think it's important, and we have learned this over the years, and I think that nowadays we are clear that there is no decision about the patient without the patient, and the patient's preferences and the patient expectations are really important, and we need to really be aware that this is something that the patient can have a good cosmetic outcome seen by the breast surgeon, but if it doesn't meet the expectations, it will be a bad cosmetic outcome. So it's not only about having a good cosmetic outcome and the way we evaluate those cosmetic outcomes, but also it's about, you know, what is the expectation of the patient and the preferences. And I like very much this sentence about Veronesi, you know, the restore of humanity when we talk to the patients. And now, you know, we have the artificial intelligence, and probably in breast surgery, in breast cancer surgery, it's becoming a little more slowly than it has been in other part of the breast cancer patient pathway. And I think it's important that we see that, you know, in a screen and diagnosis, it's already there. Predictive models for breast cancer risk is already there. Reparative planning, pathology, it's already there. Postoperative care, in some cases, there is something going, and I think that, you know, we need predictive modeling for surgery outcomes, and I think it's important. Also for improving surgeon training. So I think this will be a very good starting point for this. I think that, you know, at the end, we will not stop doing surgeries. We will just make surgeries less invasive, more targeted, and more tailored to the individual patient needs and expectations. And I think that the results from the Cinderella will be something that will give us another dimension of understanding what is the patient expectations, what are the patient's outcomes, because we already know that we are taking care of the oncological outcomes. Now we need to focus on making the life of our patients more satisfied and with a better quality of life along the years that they live. So thank you very much again for having me here, and happy to answer any questions after all the lectures. Thank you.
Thank you very much, dear Isabel. Very, very extensive overview. Thank you also for the insights that you provided us. Please ask questions. Do not be shy. Otherwise, I will have to ask all the questions. So please help me to do this. Otherwise, I will have to ask all the nasty questions to the speakers. So the next speaker is Philip Poortmans. He's a radiation oncologist. Everybody knows him. He's the former ESTRO president. He's now at the Iridium Network and Antwerp University. And Philip is going to talk us about late radiation effects, factors influencing aesthetic outcomes. Please, Philip.
Thank you very much for the invitation and the introduction. It's an honor and a pleasure to present some data that are not directly but indirectly strongly related to the Cinderella project. So since the 24th of February 2022, I mentioned this, my worries, I share my worries with you about the future with all the regional conflicts and wars ongoing, and I really hope they come to an end soon. So if no conflicts of interest, short introduction, we switched from the 20th to the 21st century from essentially field-based radiation oncology to more 3D volumetric volume-based radiation therapy, which allows us to much more precisely target the target volumes and give a much more conformal dose delivery with lower doses to the organs at risk. And this will further allow us to go to the era of adaptive radiation therapy, where we more and more can correct for changes in the tumor, in the movement, and in the volumes. When we speak about breast-conserving therapy, we try to balance the local relapse rate with the cosmesis, because both are very important for the future, the quality of life of the patient. And indeed, we switched from maximalistic to minimalistic. And initially, we were looking for how can we improve local control by increasing radiation therapy, for example, in the famous Boost-No-Boost trial, which indeed showed that giving a boost, a higher dose to the primary tumor bed, reduced the rate of mastectomy by about 5% at 20 years, which is clinically significant. However, it had no benefit for overall survival, and it came at a price, a doubling of the rate of moderate to severe fibrosis, thereby impacting on the cosmetic outcome. And this is an overview of the cosmetic outcome in the time of the EORTC trial, which is, let's say, 30, 35 years ago, where with a boost, 71% had a good to excellent cosmetic outcome. However, when we switched 15 years later to the Young Boost study, we thought it would be better. The reverse was true. We saw even a worse cosmetic outcome, and a lot of those centers were overlapping. Of course, it's not the same trial, not the same era. So what went wrong? Why were we doing worse with more modern technology, especially because we increased our boost volume? We saw much more, and we thereby gave the boost dose to a larger volume. And maybe also oncoplastic surgery has a role here, as we demonstrated in an analysis in Tilburg, published in European Journal of Surgical Oncology. In the meantime, the rate of local recurrences decreased a lot, from 20% in the 80s to 10% in the 90s, and in the young boost trial, it's 4.2% after a conventional boost at 10 years. So we have to take this into account and only deliver a boost when needed. Then we said, okay, maybe we can do smaller. And we have criteria to select patients for so-called partial breast irradiation. Essentially, these are the patients who have a lower risk for local recurrences, a lower tendency of the tumor to spread without the breast, so that you can treat a smaller volume. These are some outcomes of the first trials. It was with a, what we call now, quite aggressive radiation therapy schedule with 2 fractions per day, quite high fractions, so 10 fractions over 1 week, and it led to an excessive rate of fibrosis, completely unexpected at the time. So in fact, in these studies, partial breast irradiation did worse for the cosmesis compared to whole breast irradiation. In the IRMA trial, which worked on that, but improved by smaller volumes, we already saw that it was less pronounced. Here you can see rates of 4% versus 1.5%, not anymore the nearly 10% grade 3 and 4 side effects like in the older trials. But anyway, we learned from radiobiology that this was too strong, too hot. So in more modern trials like the Florence study, we used a more modern fractionation schedule, and they extensively evaluated the outcomes. And the outcomes here were very good. Also in the import low trial, where the same fractionation was used as for whole breast irradiation, they showed that partial breast irradiation had less impact on fibrosis and thereby may be better for overall cosmetic outcome. The same in a Danish trial where they compared whole breast with partial breast with the same fractionation schedule. So fractionation has for sure to do with it, and I cannot speak about partial breast irradiation without showing an example of the Jack Estro study with brachytherapy, giving the dose to very small volumes and excellent cosmetic results. Then maybe we should move in first, because if you do first a lumpectomy, it becomes quite a challenge to define the target volume. While if you have the tumor still there, you can give much more precisely to smaller target volumes your dose, because part of that target volume will thereafter, of course, be removed. And in the PABI study, including about 150 patients, they showed that the cosmetic outcomes were much better than expected, and they improved over time. For example, the patient 1 with the treatment here, patient 2 with the treatment there, you see that it even improved also for fibrosis. So this can be considered as a normal post-radiation and surgical repair process. And we want to do it faster. So faster means in less fractions and shorter times. And we have shown that hypofractionation has less side effects than the 20th century fractionation with 25 fractions over 5 weeks, 5 times a week. Independent of the fractionation schedule, we have to take care that we give homogeneous doses, because an overdose to part will have an impact on fibrosis and outcomes. So what are the determinants that we have to take care of? Now, first of all, it has to do with experience, but also with how reliable can we define the primary tumor bed to contour small volumes and thereby decrease the risk for side effects. And oncoplastic surgery is a big challenge. This is the patient before oncoplastic surgery. This is during the surgical procedure. And when the patient is sent to us, we receive her like that. And then we have to look for the primary tumor bed. And often we will end up with whole breast irradiation. However, there are guidelines that we should use, I actually use, and more of us, to precisely define where originally the tumor was located, and thereby to reconstruct a target volume, taking into account as much information as available. Now, this is a patient who participated to the boost-no-boost study. This was before the radiation therapy. Of course, if the surgery doesn't have a good cosmetic outcome before the radiation therapy, we can never make this better. And then you have patients with comorbidity, like this lady. She had some effects on the skin and the subcutaneous tissue. She had several factors which are bad for the vessels. Another patient with a large breast, you see often skin reactions in the folds. With modern technology and modern fractionation schedules, much less. This is from 2007. And here a patient with a very small volume, where of course resection of the tumor has relatively more impact on what remains. There is a volume effect. The larger the boost, the more the fibrosis. So keep the boost volume small, which has also been demonstrated by the Danish in their partial breast irradiation trial, showing a clear relation between tumor diameter and irradiated volume, but also a relation between the irradiated volume and the risk of fibrosis. So we have to take this all into account. Impact of age, smoking, and boost interrelated with the volume. This is the volume, 50 to 64 years of age. A never or no smoker has little impact on the frequency of fibrosis. However, with smokers, you have more effect, and it also increases with the volume. And this is more pronounced in elderly patients. Old, 65 years is still young, but you see that an increase in volume does influence the rate of fibrosis. The import low study showed that the whole breast versus partial breast was better for fibrosis, but something in between was already very close concerning fibrosis to partial breast, and all three had a quite favorable local control rate. So that means that we should learn to taper off the dose the further away from the primary tumor bed. So take home messages. First of all, yes, we do too much screening, too much diagnosis, too much surgery, systemic therapy, radiation. We have to look critically in our protocols and decrease wherever possible. Long-term cosmetic outcomes have also to do with other factors. I have treated in the boost-no-boost trial patients at the age of 40, and when I saw them back 20 years later at the age of 60, there was an effect of weight gain, which led to an increase in the size of the other breast, while the breast that was treated remained much more stable. And of course, we all know the famous physicist Newton, which also has an effect and interaction with this. So when we balance local relapse with cosmesis, we have to take all those factors into account, because for breast conservation, you need tumor control. We know the risk factors. Nothing is better than the original, better than a mastectomy with reconstruction. And we have to balance our dose prescription and the target volumes to maintain it. For the evaluation, fibrosis, cosmesis, the involvement of the patient, it's something which changes over time. Cosmesis can be excellent after 5 years, but might differ after 15 years, while when the other breast is increasing in volume. A lot of factors to take into account, and whole breast irradiation for most patients will also give good results. I did a lot of surgeries together to learn how it all works, and that is a great benefit for me. And these are the people I would like to thank. And the final slide, thanking also the Cinderella project, is a book that we edited and published recently. Thank you so much.
Thank you very much, Philip. As always, very clear, very precise, very informative. Okay, so before we move on with the next speaker, again, I ask you to ask questions. Just let me specify that we are not allowed to to give answers to single specific clinical situations. I'm sure that you can understand that. And now it is my pleasure to introduce the next speaker, who is Maria-Joao Cardoso. She's the head of breast surgery at the Champalimaud Foundation in Lisbon, Portugal, and she's also the PI, principal investigator of the Cinderella trial and the leader of this project and initiative. So Maria-Joao will explain to us what Cinderella is all about.
Thank you. Good afternoon to everyone. It's a pleasure to be here and to share a little bit about this baby we try to carry on with artificial intelligence in surgery. So, okay. So I have no conflicts and a little bit not focusing on what Isabel already showed, but thinking that yes, we have lots of breast cancer in the world. It's prevalent, women are surviving more and more, and we estimate that 30% of the women live with not so good outcome of breast surgery and radiotherapy. So we're talking about the local regional treatment. So the background on this is what Isabel already said. So we are sure about oncologic outcomes and time to diagnosis. So this is quite easy to evaluate if we have data. But these survival rates that are increasing makes even more demanding the fact that we need to understand how quality of life is improving. No standard routine method that allows us to classify the aesthetic result exists. So, for instance, Philip was presenting the results of aesthetic outcome, but all these trials that he was talking about, each one of them used a different method to evaluate fibrosis, aesthetic outcome, etc. So it's always very difficult to translate this into a practical issue. Patient evaluation, what we call, so it's very important for us to understand if the patient is satisfied, but it's very dependent on concomitant factors, age, social status, if I'm happy, if I'm not, depending on literacy, the knowledge about the type of surgery and result, etc. So I'm sorry, but we need and lack a standard method for aesthetic evaluation that allow us to compare results and to allow us to measure something that will be meaningful. Because when we talk about oncologic outcomes, we know what are the metrics. And here it's very difficult to know what are the metrics. So we need to have these quality indicators developed. And Isabel already talked about what is the impact that we have on women when we tell them they have a breast cancer and they need to decide on something. And usually nowadays, it's not to decide on one thing, it's to decide on several things that have impact in appearance, in financial issues, treatment issues, etc. This year, so published last year online, the EOSOMA quality indicators for non-metastatic breast cancer for the first time included the introduction of some parameters that are going to be important. So the fact that we have the images of the patient before and after surgery, and we have at least a small number of patients that are submitted to a questionnaire about the quality of life. At least. And this is a problem because we are always discussing if aesthetic outcome is a surrogate for quality of life or not. And this is a problem because when we are evaluating aesthetic outcome, are we getting to quality of life, or is quality of life by itself only including aesthetic outcome in a different percentage? And this is something that we also want to know. There are lots of methods to evaluate the aesthetic outcome. As I told, the majority of former trials used a panoply of methods. So subjective is the most common, so ask the patient how she feels about the result, but there are also some objective methods. In fact, none is standard. In the majority of breast units, no outcome evaluation is done, except if you have including patients in a trial. In the majority of breast units, no photographic documentation pre and post-treatment is done. And we have this from the Italian breast units. There's a nice paper about that. And the number of units that have pre and post photographs is really small. And in the majority of breast units, no standard pros are used routinely. And this is the reality around the world. So we need this for guidelines, benchmarking, accountability, and to use and to test to try to improve outcomes. So what are we now in terms of we call tools for appearance counseling? So when we want to counsel our patients, not only regarding the types of surgery we have, but what will be the result of the surgery. So we have the old tools that we all know, videos, pictures, plastic surgery galleries, where we can show to our patients what is the supposed result. And there are some new tools using AI. So we have breast surgery galleries that match the patient's photographs according to a gallery that is using machine learning to pick up pictures. We have the recommend decision systems that use breast decisions. So it's like a patient decides to have something, and then there's a dichotomy of decisions according to the expectation the patient have. This is used mainly only with reconstruction. And then we have the Cinderella approach. That is a more complete one. I'm going to try to explain what we do in the Cinderella. So what we want is to evaluate patients' expectations, standardize information about local regional treatment, try to give the closest possible image of the expected aesthetic outcomes, and see how this all correlates with quality of life. So this is the teaser of Cinderella. Imagine if you could show to your patients how they will look. And we have this Cinderella approach is based on two things. The build of a platform, of a system that will allow the patient to have all this information and the access to the pictures that are generated to the artificial intelligence model, and the trial that will test these tools that we develop during the first part of the project. So this is what was shown in the video. So all the countries, the technical partners, and the academic partners. And this is how we show to the patients when they are randomized between the control arm and the intervention arm. The patient have access when they are in the intervention arm to an app that in any of the 6 languages that we have will show them information that can be in a simple level, in a normal level, in a very extensive level, in those patients that want to know absolutely all about complications. And this is divided by all the types of surgery that we know. And then the patient has also access to videos with avatars about the surgeries and the photographs that are matched by their own breasts. Not by biometry, not by weight or age, but by their own breasts. And they have excellent results. They have good results, medium and poor results that can be selected. This is how the artificial intelligence application connects with the app that the patient has to select the pictures. So there's a vast data set of pictures, and the selection of pictures is then passed to the patient. This is the design of the trial. So we have the patient population. They are randomized 1-to-1 between the interventional and the control arm. And the primary endpoint is the match of expectations for the patient between the pre-op expectations and the post-op expectations. We also have as a primary objective to evaluate how the patient that falls in the intervention arm can match the automatic classification of the AI module, because that will lead us to the impression that if we teach the patient how she's going to be, she's better qualified to evaluate the outcome. We have also secondary endpoints related to quality of life, again, to try to understand if this is a surrogate endpoint. And just to show you that we are here. So we are at 700 patients now. We hope to attain the 1,200, but this was a very important milestone for us. And we have also some other very interesting thing that is going to be presented in San Antonio, is how the patients use the app. Of course, we cannot show results of the trial per se, but we can show the use of the patients, the app usage by the patients, according to countries, according to age, according to before and after surgery, and before and after radiotherapy, and average time of use of the app. And this is very interesting. Let me just say that is identical in all countries. So we are not different according to app usage. I think this is going to not to unveil everything that it has about using AI to show to the patients how they will look, but it's a start. This will continue to go behind the trial. So we want to put this product in the market, and we want to update this constantly so all patients can have access to this type of solution. This is our advisory board, and I thank everyone, and I want especially to thank the team that is big and committed, and all the patients that already participated in the clinical trial. So thank you so much.
Thank you very much again. Excellent, fantastic talk. You clearly explained to all of us what Cinderella is about. So we have now the last speaker before we start with the panel discussion. So it is my pleasure to introduce Gil Morgan, who is a clinical oncologist from United States, and is also the director of the OncoAlert Network. And Gil is going to give us a very interesting talk with a very interesting title, so Tools to Educate Patients and Doctors. Gil, please.
Thank you very much. And thank you for this kind invitation and opportunity. Going in the style that everything nowadays is being done online, and we are using a lot of platforms, a lot of apps, I decided to focus on tools that we can actually find on our day-to-day that can help us in the education of not only patients, but also for the doctors. So starting off with social media, and of course, I spent the majority of my time in social media, not playing around, but disseminating and amplifying reliable oncology information. In here, if you want to get the latest updates on what the scientific community is doing, especially our oncology community, I would advise to have a strong presence on X, what used to be Twitter, and of course, LinkedIn. And the reason for this is because a lot of the information that is being discussed, it's being discussed by colleagues. It's been discussed in a way that is not only academic, but in a way that is also interactive. So you have an opportunity to engage not only as a colleague, but also as a patient. If you have a specific question, you have access to some of the world's top scientists, top oncologists, and the opportunity to actually put your questions forward. So here, a very normal way of sharing information is by a normal social media share. And this is just a normal tweet that OncoAlert posted on a specific trial. So if you look, what we do is we normally give just the title of whatever paper just came out. And then, of course, give a synopsis or a breakdown of what is actually being discussed. Once you have that, if you look in the bottom, you can see that there's reposts and there's likes. So it might seem silly to focus on that, but at the same time, you have to remember, we come up with one specific article that we're trying to share. Now, if it's coming from a strong account, that strong account is going to share to some extra people. And by getting those reposts, that means that the message keeps on propagating into the right networks so that that message is able to be delivered to even more colleagues around the world. So this is a very good tool to actually amplify good oncology messages. So we do this, and by doing this, we reach new networks. And our aim is actually to be able to reach as many oncologists as possible. And these are the kind of oncologists that don't really have too much time to go through all the papers and all the literature happening. So we try to just make it easier on colleagues. At least that is my goal. And I do it in a way that if I can create it in a way that it's almost ready to consume with no heavy lifting, then that probably increases the chances that more people are going to be able to see it, to digest it, and to use it. So if you receive most of your information from a specific source, what you can actually do on social media is you can put those specific people on a list so that you don't have to rely on your own algorithm when you go into a platform. You can go into that list and you'll have a group of people that you normally follow, and you'll have a very clean social media feed that is just oncology. Now, moving on to webinars. Webinars like the ones we are attending now are great. If you remember, webinars were not that much of a thing pre-pandemic, but then when COVID happened, here we were, everybody was going hybrid or virtual, which was actually a very good way of doing things, because before it was almost required that you showed up to wherever that meeting was held. And it allowed us to become a lot more flexible. And it allowed us to see that there was a lot of opportunity in passive learning. And that is exactly what we're doing now. We have these discussions and we can log on and watch these discussions as they go on. And of course, in webinars like this, where you have that level of interaction, which is actually very, very great. A lot of webinars allow you not only to get that information, but they allow you to get continual medical education credits. So it's something that you need to get anyway. And by being a part of these webinars, you actually get the knowledge that you need. So this allows us to have experts from around the world, which we've had before, but because of their connectivity, experts no longer have to be in place. And what that happens is that we can actually create these webinars a lot cheaper, which allows us to actually have more of these webinars and to be able to create more educational opportunities for colleagues. Podcasts are something that they are allowed of. There are so many podcasts that if you pick a specific tumor type, you will probably find more than 10. So it's very important that you find one that you like. So you have to take the time. One of the things that we have to remember is we all have time, a little bit of time, not that much, but maybe a commute to work, or maybe when we go to the gym for 5-10 minutes, we put on those headphones and we can actually do a lot by listening to podcasts and going into that passive learning phase. So if we use that time to keep ourselves updated, even if we give 5 minutes a day to podcasts, a Monday to Friday, then we're talking about 3.5 hours to 3 hours of oncology data that is actually coming into your brain in a passive way. So it's actually a great way to keep up to date without having to do much. You just have to listen. Going into educational meetings and going into what we said about the pandemic, a lot of it started coming to be virtual. So now these virtual meetings seem to be here to stay. And the reason that they're so popular is because everybody can attend. It doesn't matter who you are. Sometimes when it comes to these big meetings, our junior colleagues don't have the opportunity to go, or maybe they come from a clinic that really needs them there, or they have economic hardships, or maybe they just don't want to add to the carbon footprint. So these meetings actually require you to travel, whereas the virtual meetings, you can just show up, log on, and not really miss any time from the clinic. So one example is our end of the year review, which we have every single year, which of course a warm invitation to anybody who would like to join. And this is delivered by some of the top oncologists, and it's done so with in partnership with great societies like ESSO, ESCO, MASC, and CEOG. So we have this in a way that we are trying to make things easier for people to access these meetings. And there's a lot of meetings like this. So what I try to do when thinking about these meetings is I try to break down as many barriers as I can. For example, this meeting, along with it being once you register and you see it, all the lectures are on demand. And then, of course, when you actually are looking at it, I understand that there are a lot of our colleagues that don't have English as their mother tongue. So what we added is we added subtitles in English, in Spanish, and in French. That way we cover our colleagues from Latin America, and we cover our colleagues from French and from French-speaking colleagues from African countries or Asian countries. So this is a really good way to decrease the amount of hurdles that are out there. And there are a lot of other meetings that are doing the same to facilitate the learning. There are Facebook communities that we can actually learn a lot from, and our colleagues from the rare cancer community have actually done an amazing job at this. So by using these communities, they not only learn from each other, but they have been able to harness this community to actually conduct research. And this is research that is being led by patients and patient advocates in collaborations with doctors. The use of websites, there are many websites out there that actually provide good, reliable oncology information. We have our own website, and then what we try to do, as I said, we try to cover the top trials that are out there. We try to do the coverage of all the different congresses that we have, such as ASCO, ESMO, San Antonio, in a way that is easy and it's easily digestible for our colleagues. And last but not least, there are applications. I have no relationship with OncoAssist, except that I used OncoAssist. I think this is a good application that is out there. There are many different applications that are feeding you information as well, current information that is often coming from social media. There's a lot of different videos. So the main thing is to download applications that are going to help you, better understand whatever you're trying to treat, and if possible, applications that are going to help your networking. So that is my wrap up of what I think are the different sorts of educational tools that are out there. And of course, encouraging everybody to jump in and don't be afraid of social media and these tools.
Thank you very much, Gil. Excellent presentation. Thank you once again. So now we can start with the discussion, and therefore I can also invite the other two panelists to the forum. Orit Kaidar-Person, who is a radiation oncologist, and she's the head of breast radiation unit in Sheba Medical Center in Israel. And also Carina Dantas, I hope she joined, who is the CEO of Shine to Europe, and she's also here as a patient advocate. I don't know, Carina, if you're here.
Yes, I'm here. I don't know if you see me.
Thank you. Thank you very much.
Yeah.
Thank you very much for joining. Okay, so we can start with some questions at first. So, well, we have a few questions in the chat. So the first of all, it's so nice to ask questions rather than giving answers. So it is really fun. there's a first question, very technical. I don't know if anybody is able to respond to this. So from Venezuela, they are asking what type of AI is used for the algorithm in Cinderella project? Machine learning, deep learning, convolutional neuronal network. How many layers?
So we are using machine learning. I think Tiago is here, so and is responding all of them. So if you want to know a little bit more about that, you can contact our technical partner, INESC, but they are using a little bit of all these techniques to get to the best image possible. So it was Victor, so
Yeah.
yeah,
In addition, sorry for the interruption, we will have a webinar about AI with all our superstars in AI research and planning with Ines and Concado. So the time will be published at Cinderella webinar.
Thank you very much, Orit, for pointing that out. Yeah. Well, MJ, since you're there and you jumped in, so I want to ask you a question about the possible drawbacks. Do you see any possible drawbacks of artificial intelligence in general and of the Cinderella approach specifically?
Yeah, I see them. I think the global efforts, so just pointing out, so our aim is to help patients to decide better, okay? This is our aim. We have been doing this for 700 patients, and we know that some patients don't want to participate, don't want to see pictures. This is one of the drawbacks. There's no drawback regarding languages because, of course, in the future generations of Cinderella-like applications, we are going to use all languages because now with the new language models, we can do it easily. So we have no problem with that. But I think is all the usage of high technology are very good, but they are not completely inclusive, okay? So you have people that are not going to use it, and you know that. So usually older women, so we're talking about over 80. It's not general, but it's more frequent, don't want to use it. Of course, this is going to change along the way, but I think we have different types of women, different types of culture. Some people don't want to see their images. I guess that this trial will not have a huge acceptance in the Arabic countries, but it's also something that can be helpful in Occidental cultures, I think.
Thank you. Orit, you want to add something?
Yes, I wanted to add also, there was a question in the chat about AI. I think it was Tiago. How do we want to implement it, or are we open for it in clinic? So at first, when we started the project, I was a little bit fearful from AI, and I guess some of our patients are as well. But as we dive into the project, I think this app will be essential. It will be something that everybody will need at clinic, because and this is how all the talks show that, because Isabel showed how you have different surgeries for different patient, and the same surgery can have a different outcome for a different patient. And similarly, Philip showed about radiation therapy. And when you have this patient visit in clinic, sometimes it's very difficult to communicate. It's a very intensive meeting to talk about breast cancer, and the patient can use the app in her comfort home with her family feeling protected and diving into the information as much as she wants. If she wants little information, she can open just a few uh, uh, things in the app. But if she really wants to see movies and learn about the surgery, it's there it's validated by doctors and researchers. So I think this will be the future of communicating with our patients.
Thank you very much, Orit. I totally agree with you. I think that the patients that are joining the trial are very happy, and also the fact that they can have access to information coming from sources which can be which are reliable. It's very important, so they do not have to go out online and look for information, and they can just click on the app and get all the information that they want to know. Carina, you want to say something, please?
Yeah, if I may, it was a bit connected to the potential limitations that you were discussing with Maria-Joao. I guess one of the things that you need to handle is the expectations of the patients. Once, I mean, if at the end they can, if they expect some wonderful result and they get somehow defrauded by the images, or the contrary, if then they get to expect too much that perhaps cannot be delivered. Do you think anything like this has happened? I think it would be an interesting point also to understand from the trial what has been happening on that.
At the current moment, it's quite difficult to disclose exactly that. So I think we are prepared for all the possible scenarios, okay? We didn't have to confront with a patient that said, I was completely devastated by the images, never. So I think it's something that we'll need to analyze at the end. So it's a huge amount of patients, so we need to analyze this at the end. In a general way, the message is strongly positive. And what I see is frequently patients that are randomized to the control arm saying, what the heck, not to me. It's like, I wanted this and I don't want it. I don't get it. So I think we are going to have some results like that. So we are also exploring. So this is another thing that came from Rosa, that is working with Oreste, is trying to analyze the patients that don't want to enter in the trial and try to understand why they don't want to enter in the trial. And this is a project that Rosa started. Everybody went on. So this is amendment to the project, to the initial project, because we think it's very important to understand why patients don't want to enter the trial. And this is something that is also going on. I cannot, it's very difficult. There's a lot of centers doing this, so it's difficult for me to understand. But in our center, I never had the shock of a patient saying, I was devastated to look at the pictures. Knowing that they receive different kinds of pictures, from excellent to poor. And what they frequently ask is, I can get the poor result, and we say yes, it's not so frequent, but yes, you can get it.
Yeah, I think this is a really interesting part, especially because as well as former patient, I think this aesthetic part was really not considered that much in all of the options throughout the treatment before, when I was on surgery, which I think is quite common because we are very on treating. But then the aesthetics remains forever with you. So are doing is really exciting. And
Carina, sorry,
this is a bit also why
is not perfect.
this route.
Carina,
Okay.
your sound is not so good. Yeah.
Oh,
Okay.
Yeah,
Now it's good.
perfect.
That's good.
okay, sorry. So I was just praising you and saying how important it is, this work. I hope you heard that. And also hope
Yeah.
that at the end, the outcomes of the trial allow us to understand a bit more how to integrate this in common care, because I think it would be really interesting.
Yeah.
I hope you could accompany it now. Sorry.
Yeah.
Thank you very much, Carina. Isabel, I see a raised hand.
Well, just a comment. I think that, you know, if the trial results to be helpful, that I'm sure it will be. I think that for patient is much easier just to go into an app and look into photos and everything, that if you tell them that they are going to be in a clinical trial. Because we already do that with plastic surgeons. You know, we have all these brochures that they see and they never say, I don't want to see them. But, you know, at the time that they have to choose whether to see or not, maybe the thing going into a clinical trial, it's more like, okay, well.
Yeah.
Well, I see a very interesting question coming from Mexico. Maybe MJ, you can answer this. Do you have a plan to integrate images of women with different races and ethnicities in the app?
Yeah, we have, and we had. The question is, we need to understand that data protection and image protection is a nightmare. So we have a very strong desire to collaborate with Data Memorial in India. They were very interested, but then the regulations about, because the algorithm, of course, cannot work without having the images. So they could not share the images. So it was like a bucket of cold water, because it didn't work at all. So what I think it's going to happen is when we finish the trial, we of course will publish the results, but we are going to go with a solution to have this in clinical facilities. And we are probably at that phase trying to have more countries, including patients, and using this. And in that case, maybe, so we can find a solution to use their images without having the access exactly to, so having anonymized images to have the access and to use their images in their own patients. At this moment, I would say that the majority of our patients are white patients and Caucasian, and we don't have many other racist patients. And this is, of course, a pitfall, but we knew that. So I hope that when we go into the go-to-market strategy, we have then a new possibility to study this in other environments. At the moment, it is what it is.
Well, and also I would like to ask a question to both Isabel and Carina about prompts, prems, questionnaires. So we know how much these are important, but I recently read a couple of papers from UK, and the percentage of patients actually filling out the questionnaires appear to be, let's say, disappointing. So we are in the range of 30%.
Yeah.
Could you please elaborate on this? What are your thoughts about it?
Okay. So what is the problem with the prompts and the pros? The main problem is that I think that in the next years, the institutions or the cancer centers or the breast cancer centers need to have a department for prompts and pros. And they need to have those questionnaires that the patients fill inside the electronic chart individually, so the breast surgeon or whoever the specialist taking care of them will notice about those prompts. The problem nowadays is that there is no consensus on which ones are the best to use. You know, we have the breast Q, we have the EORTC, and at the end, you know, there is no one that is ideal. But the second part is that, I mean, we have patients who fill the questionnaires, but nobody really put those questionnaires inside the electronic chart, so you can take advantage of the questionnaire. I mean, if the patients fill the questionnaires, and we've seen, at least, you know, in my practice, that patients are willing to fill it and they don't have a problem with that. The problem is that, you know, there is nobody who is going to translate that into the chart. And at the end, if you cannot improve anything on an individual basis, I mean, what's the point of all that? So I think we need to really start thinking about having a department in the institutions. I think this should be taken care at the institutional level, because these things happen with breast. Probably breast is more impacting on the quality of life and satisfaction, because all the related issues about cosmetic outcomes and the impact in sexual life and all that. But colorectal cancer patients has the same problem. They have many problems with the surgeries, with the treatments, and we only have things that the only problems that we know are the ones that in those patients who are on clinical trials for whatever reason. So this is my point of view. Until we have not that, I mean, we won't be able to make any impact on an individual patient with their problems.
Thank you, Isabel. Carina, you want to add something about this, about prompts and what will be the future of this?
Well, I'm not sure if I can say anything about the future, but I am involved in another project, which is putting together a EU questionnaire on quality of life of patients and survivors. So I think it will be at the end validated in 45 centers of more than almost 30 countries. So at the end, perhaps this could be integrated in the electronic health records if it is broadly validated and agreed on. Because I do think this would make it easier. So kind of complementing a little bit what Isabel was discussing, if we find a good validated instrument that can be used broadly around Europe and maybe beyond, that would be super helpful, because at this point cultural differences and geographic differences still make a lot of impact.
Okay, thank you. Well, Philip and Orit. There's a question again from Venezuela, and they're asking Philip if in his everyday practice, is there a substantial cosmetic difference between patients that received hypofractionation versus ultra hypofractionation?
Well, the answer is quite simple. We don't know for sure yet. So the scores, the evaluation in the fast forward trial showed very similar outcomes within the normal variation. So we are hopeful that this will be maintained. As for cosmesis, we know from the Young Boost trial, from the Boost No Boost study, that the impact of the boost is set the first 3 years. So thereafter, the two slopes run parallel. That means that the boost has an impact, but the differential impact is not changing over time. So if this is the case for fast forward, the difference will be clinically not relevant.
Okay, and Orit, you want to add something?
Yes, I think there is a general rule in radiation oncology about how you plan radiation. If you have, like, for example, inhomogeneity, if you have large breast, and when you see all those things with regards to planning, it doesn't matter whether you use conventional radiation or hypofractionation or ultrafractionation. If you there are certain things about the patient body habitus, and if she's a smoker, for example, or have comorbidities, but also if you have a bad planning, it doesn't matter what fractionation you'll use, you'll have bad results with regards to aesthetics. And in addition, we had I was very proud to see in the chat that we had a question in Hebrew. Yes.
You didn't get it, Oreste.
I asked you, Orit,
yeah,
for
he
help.
asked me. And then I asked Natalie. So yeah. So I was so proud. Thank you. And the question was, do we see significant differences between the evaluation of the physician compared to the patient with regards to aesthetics? So I cannot reply per trial because we do not reveal now any of the results. But, and we can ask all the panelists as well, but personally, when we treat a patient, you see significant differences. Some patients are so happy, even though as a physician, you see that she has a deformity and she's just happy to be alive. While you'll have another patient that you'll see a perfect breast, something that was done with a great lumpectomy or oncoplastic, and the patient is complaining of something that you cannot even see on her breast. So I think there will be always a gap because it's associated with the physician as a physician and the patient perspective and how she sees herself. And we can never, ever understand that. It's only the patient.
Well, thank you, Orit. And I'd like to ask Gil if he has any comments on this discussion. And also, I would like also to ask him one question, because I had the opportunity to listen to one of his very interesting talks in one meeting a few years ago. And you were speaking about this 8-2 rule, about how to behave in social media, because a lot of people is continuously posting and delivering contents about himself, herself, themselves, not delivering contents of other people. Could you please explain and tell us something about that?
Absolutely, Oreste. Well, actually, going back to what you were talking about, prompts and the use of different questionnaires, what I wanted to say is something that has had a lot of success, at least in some trials, has been when it's associated to an app, and patients can actually access that app. But as you say, it's something that you need to have that app installed, and you get those little prongs where it's like you can fill out either a questionnaire or constant questions that are coming up if you are a part of a specific trial, but oftentimes it's because of a trial. So going back to what you say about the 80-20 rule, and thank you so much for the compliment. I'm glad that stuck. As you know, I'm on oncology social media for a while now, and the 80-20 rule is something that we really base our whole existence on social media on, and that is that for every 80% that you post, that has to be about somebody else. It cannot be about yourself. 20% you can post about yourself. We are working in this field, and we do produce science. So we also want to be talking about some of the things that we do. But the last thing that you want to be is that person that is incredibly self-centered and just saying, okay, well, me. But, you know, in that case, it's very hard to follow you. So what we do normally with the network is the majority of what we share is just everybody else's views. Of course, we look at it. You have to, before you share, before you do anything to amplify a specific message, you have to be very sure of what it is you're amplifying. And that's why I think it's very important to have an oncologist on the other side that is actually pushing, because you have to understand the material, and you have to understand that what you are amplifying, especially when you have an account like ours that has been around for 5 years and people are trusted, you have to be careful what you're pushing and what you're not. So I think it's very important to always pay it forward and to highlight others whenever you can.
Thank you very much, Jill. Thank you. Well, okay. Meanwhile, I look for other question. I would like to ask.
I saw one.
Yeah.
About the indication for a boost. Indeed, if the tumor is removed with a margin that is so wide that the boost volume is removed, there is no indication for a boost. So leave it out. I stopped boosting for many, many years when the tumor-free margin was 1.5 centimeters and above, which is the target volume. And I also, but there I'm still a minority, stop boosting those who have pathological complete remission after primary systemic therapy, because there is conceptually no boost volume left.
Thank you, Philip. Thank you, Philip. I'd like to ask one question to Isabel, because she listed a number of potential applications of AI in our field, and you were speaking about also training and education. How could that be possible?
Well, I think it will be possible with virtual reality. I think that nowadays, you know, you can do surgeries in your hospital and you can just have someone else in another country, in another continent, learning how to do it. You can also, you know, get some training with people who are working and doing some type of, you know, with the same thing that we have these simulators. Maybe this is not as much as the artificial intelligence, but I think that the virtual reality will at some point be there for training. For training mainly, you know, for low middle income countries, mainly. We have a problem now. The thing that I'm trying to find out is how to, we will have to train residents and young surgeons in doing axillary lymph node dissection at some point, because they, you know, in the next probably 5 years,
They're not going to do it.
They will not know how to do it, because, you know, they haven't seen any, and they have seen one and they haven't done any. So I think that, you know, it will help a lot with that. It will help a lot with that.
I
Okay,
must
thanks.
say, due to Oreste, they won't know how to perform a sentinel as well.
Well, no, well, I'm not so
We'll
sure
see.
about that.
Yeah,
It will take some time. It will take some.
yeah.
Yeah, we won't see that. It will be the problem for another generation, not for us.
Well, and there's a question, I think, for MJ. How accurately does this AI predict aesthetic outcome? And since Cinderella influences patients' emotional readiness for surgery, how does it impact their overall psychological well-being throughout the treatment process?
But that they need to wait for the results of the trial.
Yeah, definitely.
I would very much like to see, but we still have 1.5 years to go before we have the results. So I don't know, to be honest. We hope that it's going to be positive, although even if it is negative, we have lots of things coming from the trial. So our questionnaires are all filled in the app, so it's again a benefit. Our pros are all filled in the app. Another thing that I was liking to talk about regarding pros and proms is that I think in not a so longer time, we will have also some more easy forms, because what Isabel is saying is independent of you answer in paper, you answer in the app. If you don't have an analysis after that, it doesn't serve at any purpose. So even in Cinderella, we are also using, and we are going to use, some natural language processing to see if it is easier to then transform this into actual structured data that will allow some simple analysis at the end. Let's see if it works. But I think it's using language models is going to be the thing, because although you develop tons of quality questionnaires, they are not standardized. And in fact, one way of using the information that patient gives is using their own speech to transform this into metrics. Let's see if it works. But I think that's a very interesting field.
Thank you, MJ. There are Orit and then Isabel with the raised hands.
So just a short comment that even if the trial does not have a positive results with regards to patient expectation, in my point of view, it's a positive trial, because it will definitely improve the quality of life at clinic when sometimes you encounter patient visit, and it's very difficult to communicate to the patient that even surgery or radiation might have poor cosmesis. So I think by the fact that the patient is exposed through an app and have this availability, it's very important for open communication and an honest one with the patient.
Thank you. Isabel?
Yes, just a very brief comment. So everything we are talking about is really going to improve patient expectation outcomes. But if you are not trained in breast cancer surgery, specifically, it doesn't matter how nice the results look, the surgery will have bad outcomes. So I think that it's important for young surgeons, for those who are finalizing their residency, if they want to do cancer surgery, and we are talking about breast cancer surgery, it's imperative that they do additional training in breast cancer surgery. Because if not, nothing of this will make any difference, because the surgery will be not well decided which is the best option that the patient has. And then, you know, the skills won't be as good.
Thank you, Isabel. Carina, please.
Yeah, just maybe a quick positive note after this, which is regardless of the results of the trial, anything that can enhance patients' literacy is good. So I also see this a little bit on that perspective, which is whatever you think of it, if you know a bit more, then you can also be more engaged in the process. That also makes you less fear of some ghosts, let's say, that you may have when you don't know. So I always see that as a positive outcome.
Yeah, totally endorse this. Thank you very much. I think it's really important, this. There's another question for Gil. Do you think that in a way the post-COVID era has helped spreading scientific knowledge, making it more at hand?
Yes and yes. It really has. And actually, I think what it has done is not only has it incentivized and really allowed it to increase, but it also allowed us as a consumer of scientific information to accept this way of receiving the scientific information, like through social media or webinars. So I think this was the one silver lining, if you can say that way, about the pandemic, is that it allows us to learned in a way that we weren't learning before, and really accept it and take it as part of our day-to-day. Because nowadays, I think the majority of us have some sort of a webinar or maybe a few every week.
Thank you very much, Gil. I think we are running out of time. We have 1 minute, so I will leave you with this very last question, which is very easy, I would say. Do you think AI will take over decision-making and patient-doctor relationship? Who's going to answer that in just 30 seconds?
No.
NJ.
No.
I like.
No. I think it's going to help us a lot. I think it's not going to take over. We have many things to learn about AI still. So, but I think it can help, and that for sure.
It's like I replied to another question, which is now in the answered folder. The amount of data is increasing. It's already too much for full comprehension by most, if not all of us currently. So the integration of AI will help us, if we guide it good in a smart way, to better comprehend the manifold of data to finally come to better advices for our patients.
Okay, so it's 6:30 p.m., so it's time to close our webinar, and I would really like to thank all the panelists for contributing to this initiative, and also I would like to thank all the attendees for staying with us, for asking questions, and it is my pleasure to invite you all to the next webinar of the Cinderella project, which will take place next November 26th, again at 5 p.m. Central European Time. And the title of this webinar will be Patient Engagement and Shared Decision Making in Breast Cancer. Thank you very much indeed once again. Have a nice evening.
Thank you.
Thank
Bye.
you. Bye.
Thank you.
Bye. Thank you.
Thank you all. Bye-bye.